Hello, and welcome to the Guide online educational website, the Noble Biocare portal. My name is Steve Parel. We're going to talk a little bit today about immediate loading and the all-on-4 concept. And more specifically, we're going to talk about how to do the conversion process. There's several different ways to do this. There's a method where we pick up 2 of the 4 implants and convert a prosthesis partially and let the laboratory continue the rest of the work, or we can pick up all the sites where there are implants in both the maxilla and the mandible and complete the process essentially with the patient still there and not having to come back and forth to interrupt the patient during the recovery process. That's my favorite way to do it. That's really what I have been doing for a number of years in a situation where we are very busy doing 2 to 3 jaws per day using the all-on-4 concept entirely and using the immediate load concept as part of a business model. So I have had some experience in being able to determine which might work best and most conveniently depending on your clinical setup. And I think picking up all the sites where there are implants and converting a denture to an immediate prosthesis as a one-step operation intraorally does work the best. We'll start with the patient that you see illustrated on your screen. This is obviously a patient with some significant breakdown of dentition. But also, as you can see, there are some teeth that probably might be salvageable. There are some teeth that, in some scenario, might be able to be repaired, rehabilitated, gingivally reconditioned, and kept. What I would like to make a point of before we start is this is very much the kind of patient that I think is the most ideal for implant therapy, the most ideal for full arch reconstruction. The radiograph, the panoramic film survey, really is a roadmap. It's a roadmap to what that patient has been through over time and what you can most likely anticipate will continue to occur over a time period in the future, which means that that patient will have continuous loss of dentition, will have significant caries activity, will probably have periodontal disease that is continuing, and most likely it's a patient who has given up on trying to maintain and salvage their dentition. That's exactly what you see right here. This patient was given several options, keeping some anterior teeth, extracting all the others. Most of the posterior dentition would go. You can do that. You can place implants in the posterior sites in both the maxilla and the mandible. It's difficult to do, and it doesn't give you the longevity that a full arch restoration will. That's kind of a decision-making process that has evolved, that has changed from what we used to do with implants and what we did in dentistry in general for a number of different years. This patient actually made the decision for me when I did talk to him about what would be best in the future. This individual decided it before he even came to see us that all those teeth needed to go. He was simply tired of trying to do the reconstruction. He knew his mouth was in jeopardy. He knew he had a failing dentition, and he simply wanted something that would be much easier for him to maintain for the long term, and implants were the answer. They were the process that we will initiate and take you through as far as getting him ready to receive a provisional prosthesis at the time of initial surgery. In order to get to that point, of course, we have to do a workup. We have to go through a laboratory phase. We have to go through a clinical examination. We have to make impressions. And most importantly, we have to document so that we can give instructions to those people who are making these immediate dentures as to where to place the teeth and how to make a dramatically improved image for this individual with this new prosthesis. That's what is most pleasant, that is what is most rewarding about this all-on-4 process, and especially being able to convert a patient from not a very good presentation, as you can see on these photographs, into an individual who is very much different, more confident, and much more able to enjoy being in front of other people than the situation now as it presents. I'm a big fan of photographic documentation, and as you see, this is the kind of a format, a template I've made up specifically for the laboratory. As part of my initial exam, we will take pictures. Intraoral, full smile, extended lip position to try and get an idea where the highest lip line is, to try and get an idea where the midline for this patient is, to try and see where the occlusal plane for this patient is, so that we can perform immediate denture procedures in the laboratory and then address the patient's needs with those dentures after extraction and placement of implants in the very same manner. This, as you can see, has my handwriting on it. You may not be able to read it, but it's fine for the laboratory. And it gives them some idea where I want changes to be made. And I will try to follow the lower lip, which is the best example, the best way to create a pleasing smile in almost any individual. The occlusal plane and the midline are the two most important features of what we will do for this individual. I've marked the midline where I want it to be, and I've marked where I would like the occlusal plane to be, so you can see that it follows the lower lip of this patient. That gives you, in almost every individual, a very pleasing end result. The dentures are then made. I'm not going to go into every bit of the laboratory process to make these. In fact, the process for making immediate dentures has been around for a number of years. It's been around for almost a century, because the dentures have been around for that long. And when you really think about it, when you think about what might be the most aesthetic restoration we have in all of dentistry, you might think in terms of full mouth veneers, you might think in terms of full mouth restorations using porcelain, either metal fused or monolithic type restorations, or you might even think of dentures, which most people don't. Most people don't really realize that the most aesthetic restoration we have, and have had for years, is a denture, because we can control every aspect of that aesthetic presentation for this patient. Tooth color, tooth shape, occlusal plane, occlusion, the midline we can correct very easily in dentures where we can't correct it with natural dentition very easily at all. So using the concepts of dentures and applying those concepts to the implant restoration that we're going to make for this patient allows us to do some dramatic rehabilitations in many individuals with failing dentition or individuals with dentures themselves. This is what I'd like to do with the lower denture. As you can see, I've added 2 ball attachments by instruction, per instruction to the laboratory. That allows this denture to couple together so that we have the denture in occlusion and held in a relatively tight occlusal contact position. That is a very nice feature to have at the time of surgery, because it allows the patient to simply close into that lower denture without having a number of different hands to hold everything in place. You'll see as we go through exactly what I'm talking about. I also like to add little finger rests, if I can, on the lateral side of the lower denture, which helps me control the denture during the conversion process in the lower arch. Let's get on to the day of surgery now that we've gone through the various steps that are needed to create a prosthesis this patient will have for me to be able to convert, and start with the very most important aspect of the surgical process, and that is recording the vertical dimension of occlusion. This patient has natural vertical stops. I want my prosthesis to have the same VDO as his natural teeth now give him. And being able to record those natural stops by either a dot on the nose, a dot on the chin, a line somewhere, a dot somewhere else, and measure the measurement, I am able to reproduce at least the VDO following extraction of all the teeth and placement of the implants very readily. The most important thing to realize is that you don't need a good Samaritan in the room who cleans this patient up after surgery and takes the dots away for you. I need those dots later when it comes my turn to make the prosthesis for this patient. So make sure you protect the integrity of the dots. We put tape over it. Everybody in the room knows, do not remove those dots. Following that, it's up to the surgeon. I have a surgical script as well, mostly based on the photographs I have taken from the original examination process, and that script will tell the surgeon how much bone we need to reduce. One of the most important things about any all-on-4 procedure is making sure you create enough room for the prosthetics. It's sometimes very, very tempting when you have a beautiful arch, lots of bone, huge ridge forms, to simply place implants in nice positions and then send the patient on for reconstruction thinking that you have the best implants placed in all of the world. In fact, that may be true, but it also constricts dramatically our ability to make a prosthesis because we don't have vertical space. I want 13 to 15 millimeters from the incisal edge of my prosthesis to the tissue, which means I may need 17 millimeters to the bone in order to leave me enough room to make a prosthesis. And I have passed on those instructions to the surgeon. This particular script is in the operating suite. When the surgeon begins the process, he consults his script. This is what I make up for that particular process. And the surgeons are fairly aggressive in removing bones in our centers. The surgeons will take bone away as necessary, especially in the anterior and hopefully in the posterior, to allow me to have room, to allow me to have the space to make the prosthesis both provisionally and in a final form. Also to allow, because we have recorded the high smile line for the patient, also to allow for us to be able to hide the transition zone underneath the upper lip. All of this is programmed, all of this is pre-planned, and we also give the surgeon, as you can see, the horizontal reciprocating saw in this particular slide showing the removal of bone in gross fashion. We also provide a guide, a surgical bone reduction guide for the maxillary arch, which is simply a duplicate of the immediate denture we've already made. The lab does all of this for us. The lab will cut the flanges down so that we can see from the incisal edge to the cut bone surface a specific dimension, and we can measure that dimension. In this case, I asked for about 17 millimeters. 13 to 15 millimeters to the tissue, another 2 to 3 to the bone from the incisal edge of those incisors. We also have a window in the palatal portion, so the placement of the anterior two abutments can also be predicted to be positioned so they come through in a palatal aspect and not through the incisal edge or the facial surface of the teeth. Lots of information in this clear denture guide. Every patient who receives an all-in-4 is given this for surgical use at the time of surgical procedure. The implants can be placed in numbers. In this particular patient, not only do we have 4, but we have 5 implants, which was part of our original plan based on what I perceived to be some softer bone in the premaxilla than we would have liked to have had, just for insurance purposes. Rather than an all-in-4, we do an all-in-5. In the mandible, it's an all-in-4. The bone there is almost always denser, harder, and easier to manipulate with implants with a more predictable result. 4 is usually plenty in the maxilla, perhaps 4 is a standard, but 5 or 6 may be what you want to use. We'll cover some of that in another topic. The maxillary denture is used with a disclosing medium, in this case blue mousse, in order to see how it fits following the surgical procedure, following the suturing of all of the flaps, and following the placement of the white protective caps over your abutments. The abutments should always be placed at the time of surgery. The abutments themselves should always tilt a little bit towards the palatal in the posterior region to leave you less interference through the dentition in the final restoration. And when you try this immediate denture in, following the surgery, it usually doesn't fit very well. There's swelling in the sulcus, there's a lot of disruption and changes in the ridgecrest area. The suturing of soft tissue doesn't leave the tissue where it was when you made your initial impressions. So you have to utilize the disclosing concept of using blue mousse to find out where your interferences are as you seat this denture. The only part of this denture that actually serves as an index is the palatal portion. Everything else on the denture can be cut away, except the palatal. That's where the tissue has been undisturbed. That's where there has been no change in the anatomy following the surgical procedure, and that's where this denture will seat itself in a replicating position so that you don't have to worry about. That's where the denture will seat itself in a position that is repeatable using this technique that we're going to use here today. You'll notice that I have one finger in the mouth holding the denture still, and you'll notice that as I position the denture and feel contact against the palate, that there is a little discrepancy in the midline for this patient. I'm also probably feeling a little interference of the denture base hitting the white caps that are on the abutments that have just been placed. This is the first of the trials we used with the denture, with the blue mousse, to try to make sure we get the denture seated adequately and centrically on the palatal surface. I use the number of teeth to either side of the midline in this denture to determine whether we have the correct midline for the patient. As you can see if you count. On the right side you see 2 incisors and a cusp tip. On the left side you only see the 2 incisors. We also have a little bit more incisal edge here than we would like to show. About 1.5 millimeters is ideal. So we'll take the denture out after the mousse sets. We'll use our burr kit, which consists of only 4 burrs. We don't need any more than this. And we will drill with the pear-shaped, the pineapple-shaped burr that you see third from the left to reduce in gross reduction concept the edges or the parts of the denture that are interfering and keeping it from seating completely. I always use a laboratory motor or a laboratory handpiece. I do not like chairside instruments for doing this. The chairside slow piece is not strong enough, it doesn't have enough torque, and our high-speed chairside instruments simply aren't ideal for this kind of work. The laboratory instruments hold up very well, they're not terribly expensive, and we can set them up to the side where I don't have to grind in an area where dust perhaps may contaminate the surgical field. This is what the original or initial intaglio surface looks like following the use of the blue mousse, and you can see areas where we have show-through, where we want to reduce the base portion, the intaglio surface of the denture, in order to get it to seat perfectly. You may want to do this 2 or 3 times to make sure you're completely seated and exactly where the denture was designed to be in this patient's mouth. You won't get that unless you leave the palatal portion firmly and securely against the roof of the mouth as you do these trial insertions. At some point, after you have reduced the denture to the point where you like the way it seats and like the way it fits, you can put escape holes in the palate with the larger round burr, and you can create retention holes in the flange area of the denture using the smaller round burr. At this point, you're ready to do what I call the final wash. And that final wash simply is using the same blue mousse and the very same steps we've used so far to seat the denture in what we hope will be its final position. The maxillary denture is the key to this entire process. If you get it where it needs to be, if you get it right where you want it to be during this trial and then this final wash procedure, everything else falls into place. So that's exactly what we're going to do at this next step. We're going to put the final wash material in. You may not need as much as we're illustrating here. You'll get a feel for how much you do need. And then you press as hard as you can against the palatal surface with the one finger. And then before this material sets up, evaluate where you are. Evaluate your midline. Now I can see a cusp tip on either side of the midline all the way at the cuspid region. So the midline looks pretty good at this point. The incisal edge is about 1.5 millimeters of incisal edge showing. That's what I would like to have in the final restoration. We have that now. Once you have established these parameters, once you've established that your aesthetic goals have been met using this trial insertion process, you can let this material set up and then go on to the part of the procedure where you pick up, where you actually index temporary cylinders into the base of this denture. This is what the final wash looks like, and you can see very clearly that the white caps that are attached to the abutments are showing through and giving you a very exact position that you want to open the denture through to then pick up the temporary cylinders that will then be placed in the mouth. So we use a small pallet drill in the anterior implant sites. If you have an all-on-4, just use the anterior 2. In this case, we have an all-on-5, so we're going to use the anterior 3 sites and pick them up initially as part of the indexing process. The small drill is used as a pilot. As soon as I drill through the 3 anterior ones, I'll turn the denture over and note where the exit sites are on the dentate side of the prosthesis. You do not want to be coming through an incisal edge. You do not want to be coming through a facial surface. If you do, you need to stop, replace an abutment with an angled component, and move the exit sites backwards. So you come through the cingulum area all across the anterior. These are all in good position. The surgeon has a guide that will help him place the abutments so that this should happen for you. And by the time you see the patient, you should almost always be able to demonstrate guide holes right through the cingulum regions as we've shown right here. You then come back through the mousse surface with a larger round burr and going slowly with controlled speed and a foot treadle, opening these sites a little bit more, and then turn it back over to see that you have not interfered with any of the facial aesthetic surfaces of the teeth on the denture. The final burr for expanding these holes is a straight-sided, non-parallel tapered burr that you only cut with the tip. Now, since this isn't a video, I can't really demonstrate the small, slow, circular motion that I need to use to open up this hole. But just be aware, you do not want to take that burr and go straight into the hole. If you do, it'll create what's called kerfing, and you will engage too much of the resin. The denture may spin out of your hands and fly across the room. I've done that. So just as a means of controlling how you create these holes, cut with the tip of the burr in slow concentric motions circularly. You will finalize the size of the holes. While this is being done, the chairside assistant is now placing the temporary cylinders with guide pins on each of the 3 abutments that we're going to load, we're going to pick up. As you put the denture back in now, over the guide pins, over the temporary cylinders, you can look from the palatal and see that there is no interference of resin against the guide pins, resin against the metallic surfaces. If you see you're clear, then you're ready to go. You are ready to perform the process of engaging the metallic provisional components, the cylinders, against and into the denture base itself, the first step in converting. Before you do that, you want to be very careful that you protect the sulcus regions that are in this recently sutured patient, even with the best of suturing technique. It's not a totally closed circumferential area of soft tissue. There is sometimes a gap or the potential for a gap to be created, and you do not want to get resin underneath that soft tissue. So I would just take small squares of rubber dam material, poke a hole in the rubber dam with an explorer, and just stretch that rubber dam over the temporary cylinder, over the guide pin, and just pull it down to the base of the soft tissue. Do that in each of the sites where you are now going to inject resin to pick up the cylinders. That's a protective measure and a very important one. The material I like to use is called Unifast. It's a rapid setting, pink methyl methacrylate. It sets in about 2.5 to 3 minutes. You can mix it in various forms or states of viscosity, and you can experiment with it. Before you ever do this for the first time, I would highly suggest that you and your chairside assistant actually practice a few times with your syringe, your Monoject syringe, and practice how much viscosity you would like to have to allow you to inject smoothly. Practice how much of the tip you need to cut off to allow that material to extrude as you press down on the plunger tip. What you would like to do is go to the base of the soft tissue through this hole as much as you can, inject in an occlusal direction so that you fill up from the bottom, and as you will see here, actually allow material to extrude out in bulk form. This is okay. At this point, it's still okay to have this material extruding out of the hole because it means you've filled up as much as possible all of the spaces all the way to tissue level. Inject with some rapidity, but you don't need to be in a terrible hurry. You've still got time to do 3 of these. Sometimes 2 is easier than 3, but you've still got time to do 3 of these in the pickup mode that we're talking about right now. Inject. As soon as you do that, press as hard as you can on the palatal surface with your finger to make sure the denture has not moved, and then with a cotton plier, simply scrape away the excess resin so that you expose the tip of the guide pin. Now, I failed to say, but it's very important, that you put wax into the end of each of those guide pins before you do the injection process. If you don't, you can imagine how difficult it might be if you fill up the screw tip of the guide pin with resin and let it set. I've done that, and I don't recommend that you do it. Make sure you put a little protective material. Wax is all you need, and you can see the wax that's now in those tips of those screw ends that is used to keep the resin from setting up in the channel itself. Once the material is set, you simply use the driver, remove the bridge, confirm that you have a secure bond by using your cotton pliers and trying to wiggle, try to move that temporary cylinder. If it doesn't move, you're in good shape. You have actually performed the most important part at this point of the entire procedure. You have indexed the upper denture in its proper and hopefully final position to assure that your aesthetics are where you wanted them, to assure your midline's where you wanted, your plane is good, and all you have to do at this point is repeat this process in the posterior. I'll put this denture back in, use 2 or 3 of the screws to help secure it, make sure it is down tight. And we will repeat the process by removing the denture, then placing the temporary cylinders in the posterior after the holes have been drilled out, just like they were in the anterior region, and repeat the process of injecting resin. This is what the final restoration looks like, the final provisional restoration looks like after all of the sites have been indexed. This process allows me to complete everything that is needed for the laboratory to turn this denture into a fixed restoration without any other impressions being necessary. For me, for us, it works better than doing only the anterior and then coming back and have impressions have to be made on the upper and lower jaw for this patient, which is why I like picking up all of the posterior and anterior sites at once in both arches. Once you have this and you've demonstrated that each of these temporary cylinders is secure in resin, we will put the restoration back in the mouth and do much the same process in the lower arch. At this point, we will use the ball attachments, the ball clasp which you see on the sides of each side of the lower restoration to help maintain the centric occlusal position for this patient. And then we'll simply have the patient bite into, using the patient as the articulator, if you will, bite into the blue mousse and start the process all over again on the lower of removing any interferences that keep the patient from going back completely to the vertical dimension of occlusion you recorded. The blue mousse is injected, as you see here, just as it was in the upper, but in the mouth rather than outside the mouth. The patient is instructed to bite down in a centric position, holding the patient still and using the chin application of your finger and forefinger to guide the patient into what should be a centric and repeatable centric jaw position for them, which will end up being their centric occlusion. You simply have the patient close down and then measure after the mousse is set whether you have repeated the original vertical dimension of occlusion. You'll notice here that we have not. We're several millimeters short of the VDO. So we'll have to go into the mouth again, take the denture out of the lower denture, grind away the areas that are interfering with complete closure, and have the patient close once more into the blue mousse to see if we can get down to the original, in this case, 72 millimeters, which was our initial measurement. It may take 2 or 3 attempts to do that, but once you do, once you get down to the final positioning of the mandible into the lower denture at the proper VDO, then you can do the final wash just as we did in the maxillary arch and be done with the indexing process completely, not having to come back and make impressions because we're going to pick up every site for this particular patient. Retention holes are now drilled in the lateral surfaces of the flanges of the lower prosthesis and on the lingual surfaces as well. We'll inject the mousse. We'll have the patient close down one final time to do a final wash, and we'll confirm our VDO, vertical dimension of occlusion. And you'll see we are right on. Our measurement was 72. The number doesn't matter. It's simply the same measurement we had pre-operatively. And that's why it's so important to keep these dots. That's why you don't want to have someone remove them, because if you are trying to do what you're seeing right here on the patient following surgery, you won't know where the patient needs to stop when they occlude at this point. Once you've done that, you can start the drilling process in the anterior, repeat the drilling sequence just as we did in the maxilla. Start with the 2 anteriors, start with the small pilot burr, increase the size with the larger round burr, and make sure that you are not coming through the facial surface in any dimension. And normally you will see the surgeons can place these implants so that we come through the cingulum area of the lower just as we did on the upper. These are pretty much ideal implant positions, and this is what you should strive for in your communications with your surgeon. Or if you're doing your own surgery, this is where you would like to be to allow the best possible conversion from denture to fixed prosthesis for this patient. Using again that slow circular motion and the tapered straight sidewall burr, you open these up both from the undersurface and from the occlusal surface to about the dimension of the burr itself. Try the lower back in and visualize that there is no interference against any of the metallic surfaces. Make sure you put a little bit of wax on the tops of those guide pins, and once again, inject resin just as we did in the maxilla. Have the patient close down, now with the ball clasps bent out to the side so they do not interfere with closure. This is the only part that's different from what you've been doing so far. This will now be anchored on the patient's lower jaw, and you will have the patient close down without having the denture up against the upper prosthesis. Once the patient has closed down and the material has set or begins to set, you can clear away the excess so that you have the guide pin exposed and verify that you are in the centric position you wish to be. And that's exactly what you see here. The resin is setting in those holes we've just created on the lingual side of the lower. The ball clasps have been bent out of the way so they do not interfere with the patient closing down into centric position at the proper vertical dimension of occlusion. And that essentially cements the lower in the same relationship you wanted it to be in your pre-planning stage when this was made in the laboratory. So you have the ability to create a centric occlusion without having to have a perfect centric occlusion at your initial stage. That's one of the beauties. That's one of the nice flexible aspects of the all-on-4 process. You'll make sure once again that each of those is tight, nothing loose, and then repeat the process on the posterior region of the lower and send the materials that you see on this picture directly to the lab. The laboratory will then do the conversion for you. The laboratory will mount these if they need to. Actually, you don't even need to use an articulator if you pick up all of the sites at once. You can actually pour up individual casts using analogs on each of those temporary cylinders and do the conversion separately, one cast and then the other, because you now have verified and validated the centric and the vertical dimension in the patient's mouth. You don't need to put these on an articulator, which makes it easier for the laboratory. What you get back from the lab may look something like this. Hopefully the holes in the posterior are at least angled towards the cingulum or the lingual surface of the teeth. Hopefully all of the holes in the anterior will not interfere with aesthetics in any manner, which is what you see here. You have 5 on top, 4 on the bottom. You have an all-on-4 concept final restoration in provisional form for this patient, and I would strongly recommend that you reduce occlusion on one of the arches or both. This is what the final provisional restorations look like in most of the instances. At least one arch, and perhaps both, have a reduced cantilever so that the healing influences under stress, under chewing, will be minimized. These patients are all instructed to use soft foods and sometimes even blenderized foods for the next 3 to 4 months. Most patients won't do it for that long, but at least if they do it for several months, the healing is under minimal stress conditions. And if you reduce the cantilevers, those conditions are further reduced. I also try to make sure the occlusion initially is between the abutments in the posterior bilaterally and light in the anterior. And if you look at the anterior site under the mirror image right on your right, you can see that there is a gap, there is a space, which is intentional. It was designed in the laboratory to look like this. It is reproduced in the final provisional to look very much the same. Over time, these patients will self-equilibrate and perhaps recover that anterior contact, but for initial healing, it's a help. In fact, it's an imperative that we leave that area open and light in contact. I thank you very much, and I hope this is of some help with your all-in-4 patients and the conversion processes that they need to undergo. Thank you.
For more education programs, visit the Guide Institute at www.guidedental.com.